Hello everyone, my name is Carlos Ferrera. I am a cardiologist at the Cardiovascular Institute of the Hospital Clínico San Carlos in Madrid, and the case we are going to present is entitled Acute Aortic Syndrome. You cannot diagnose what you do not think about. We present the case of a 60-year-old man who had a history of inferior posterior infarction without subsequent follow-up in consultations. He was currently a smoker of 6 or 7 cigarettes a day and a drinker of 1 liter of beer a day. As usual treatment, he was taking only aspirin 100 milligrams a day. The patient went to the emergency room of a secondary hospital for 3 days of constant bilateral low back pain with diarrhea 2 or 3 times a day that had already resolved, and he also had intense epigastralgia of 1 day's evolution, and the pain did not subside with conventional analgesics. On physical examination, the patient had normal blood pressure, normal heart rate, basal saturation was also good, and the physical examination data described were not particularly striking. We can see on the left the electrocardiogram with no repolarization changes, suggesting acute ischemia or other abnormalities were observed. The analysis showed leukocytosis, 19,800 leukocytes with 82% neutrophils. Also noteworthy was a creatinine value of 3.66 with a filtration rate of 16.9 in a patient who had no previously known renal insufficiency. The C-reactive protein was also elevated, and the venous blood gases showed an acidosis with a pH of 7.21. This is the chest X-ray at the time of the patient in the emergency room, and we can see that there is no evidence of heart failure and that there is a mediastinum widening. In his evolution, the patient was also evaluated by cardiology for a very discrete elevation of troponin and for the history of myocardial infarction. A portable echocardiogram was performed with a scanning device for which we do not have an image, and there they described a left ventricle of normal dimensions with akinesia of the inferior and posterior wall and septal hypokinesia with moderate systolic dysfunction and a normal right ventricle. It was described a moderate mild circumferential pericardial effusion without signs of hemodynamic compromise and also a dilated ascending aorta, although no diameter was provided. Overall, the whole case is interpreted as a possible acute gastroenteritis with prerenal acute renal failure in a patient with chronic ischemic heart disease and moderate left ventricular dysfunction. Fluid therapy was administered and an abdominal ultrasound is requested, in which it is described as something more significant, minimal tabs of free perihepatic and perisplenic fluid and in both flanks. In his evolution, the patient remained in the emergency room for 12 hours, in which he was re-evaluated by nephrology and by general surgeons. In the early hours of the morning, the patient presented severe breathlessness that prevented him from sleeping and lying in bed. At the time of evaluation, he was sitting in the chair, tachypneic and with significant abdominal pulling. A control analysis is repeated in which the leukocytosis was even more marked, 24,800 leukocytes, the hemoglobin was normal, the platelets were also normal, and the renal function values had worsened with respect to the previous analysis, and the creatinine was already 4.67 with an LDH that was also elevated, and the C-reactive protein has also risen. The echo POCUS was unchanged with respect to the previous one, and in view of the progression of clinical and analytical data was transferred to the intensive care unit of that hospital. At the intensive care unit evaluation doors, a scanner was requested, and here we have different slices in which we can see a type A or type 1 aortic dissection with involvement of the ascending and descending aorta. We can already see in the above slices the dissection of the aortic arch with a partially thrombosed false lumen, an entry tear at the level of the ascending aorta, and a pericardial effusion. A pericardial effusion that already begins to be visualized in these slices. We continued reviewing the CT, and we see that the diameter of the ascending aorta was 47 millimeters, and that in the posterior region of the aorta there was an image that could correspond to a solution of continuity compatible with aorta rupture, and a significant pericardial effusion that measured 20 millimeters. Regarding the involvement of the visceral branches, we can see that there is dissection of the celiac trunk, the superior mesenteric artery, and also the left renal artery. Upon arrival at the referral center, the patient was already in hemodynamic shock. A transthoracic echocardiogram was performed showing severe pericardial effusion with evidence of tamponade, at which time aggressive volume re-expansion was started with crystalloids and noradrenaline at increasing doses, and the patient was transferred to the operating room on an emergency basis. On arrival in the operating room, the patient was already in deep shock, blood pressure of 50 to 30 despite volume, and vasoactive drugs at maximum dose. Anesthetic induction was performed in order to operate the patient, and the patient presented cardiorespiratory arrest in electromechanical dissociation that was refractory to resuscitation measures, and the patient finally died. We see here images of the necropsy, of the initial moment of the necropsy, in which we see how the pericardium is opened and presents a very important hematoma at the level of the pericardium that has an important role in the death of the patient. Another image of the necropsy, in which we can see a macroscopic detail of the aorta in the pulmonary artery, and we compare it with the radiological image of the CT, and we see how in the posterior region of the aorta we have this area of solution of continuity that constitutes an aortic rupture, with a hematoma that, as we can see, also embraces the pulmonary artery, and it is all surrounded by the adventitia that, as we know, is shared between the aorta and the pulmonary artery. In this other image, we show a macroscopic detail of the area of the entrance tear of the dissection in macroscopic and microscopic with a hematoxylin and eosin. We can see the entrance tear area, the intimal and medial layers, the dissecting hematoma of the aorta, and then the other part of the middle layer with the adventitia above what would be the dissection flap. Regarding the clinical presentation of acute aortic syndrome, we already know from the classic series and the IRAD studies that aortic dissection has a clinical presentation that is highly variable. However, as we can see here, most patients, 95% of patients describe some pain. In the case of type A dissection, up to 93.8% of patients describe pain. The most frequent pain is chest pain, but we can also see that up to 46% of patients with type A dissection present with back pain and 20% present with abdominal pain. Most patients describe this pain as a sharp pain, a very intense pain. Regarding blood pressure, we can see that the presentation with hypertension is the most frequent, 49%, but up to 35% of patients, almost 40% in the case of type A dissection, present with normal blood pressure. The problem of diagnosing aortic dissection is a problem generally shared in emergency departments because it has a variable clinical presentation and because this pathology is often not suspected of as one of the potential causes of chest pain. We see the data from this German study. It is a study of 350 patients with aortic dissection, and we see that in up to 78.3% of the cases, the initial diagnostic suspicion was other than aortic pathology. We see a great variety of pathologies that were suspected: neurological, acute coronary syndrome, gastrointestinal pathology, metabolic disorders, peripheral arterial disease, and we see that when this occurs, that is, when we suspect another diagnosis, this leads to greater delays in the final diagnosis, greater delays in the definitive treatment of the aorta, in the surgical treatment, and of course this has implications for the prognosis. Regarding the diagnosis of aortic disease of acute aortic syndrome, the most important thing is to maintain a high index of suspicion. In order to do that, we help ourselves with these 3 drawers, which are the conditions of risk of presenting an aortic syndrome, the previous characteristics of the patients, then the aortic pain itself, which causes intense pain. A chest pain often can be migratory, and the details of the physical examination. In the second step, we would find the usual diagnostic test that we perform in any patient with chest pain, which are the electrocardiogram, chest X-ray, and biomarkers. And we should be aware of aortic disease in patients with significant chest pain, in whom the electrocardiogram shows no evidence of ischemia, troponins are normal or minimally elevated, and we have a very high D-dimer value. In these cases, it is important to take acute aortic syndrome into consideration and request an imaging diagnostic test. In this case, the most appropriate is computed tomography to rule out or confirm the diagnosis of aortic pathology. In this patient, as we have already seen, D-dimer values were not requested, which most likely would have been very high. In conclusion, acute aortic syndrome is an entity with a variable clinical presentation. Most patients present with abrupt onset pain, and although chest pain is the most frequent, back pain or even abdominal pain can also occur. A high index of suspicion is required to reach an early diagnosis, and we should suspect acute aortic syndrome, as mentioned above, in patients with chest pain in whom the electrocardiogram shows no evidence of ischemia. Myocardial necrosis markers are normal or minimally elevated and have a very high D-dimer value, particularly when the clinical and exploratory data are not highly suspicious of pulmonary thromboembolism. Early diagnosis and prompt transfer to a referral center are essential for patient prognosis. And that is all. Thank you very much. I hope you found this case report helpful.